Medicine under U.S. occupation.
From September 1945 until the establishment of the government of the Republic of Korea in August 1948, the U.S. military government effectively ruled South Korea. The U.S. military government reorganized the colonial administration and established the separate Bureau of Sanitation on 24th of September 1945 under Ordinance Number 1, with the aim of introducing a U.S. concept of medical system. This soon expanded to Ministry of Health. The fact that one of the first orders issued by the U.S. military government was to make medicine independent of the police shows the keen interest it's placed on medicine. This was a fundamental change in the way sanitation was practiced in the colonial era, as it separated sanitation from the jurisdiction of the police and placed it in the hands of an independent organization, Department of Public Health. The independence of medicine from the police also meant that healthcare workers, particularly doctors, were directly involved in the policymaking in the nation-building period. The new medical policy, providing comprehensive preventive medical service to local communities, were difficult to implement under the old restriction-centered sanitary police system. Public health was not something that could be solved by doctors and drugs, and require a new kind of workforce that could deliver it. U.S. military government temporarily confiscated the sanitation duties of the police and assigned them to the Ministry of Health, causing great disruption in the community. Frontline police officers, reacting to the sudden reduction in their jurisdiction, refused to undertake any health and sanitation-related works. At the same time, a Ministry of Health was established at the central government, but provinces were not equipped or resourced to do the same. The result was a temporary paralysis of health administration. To compensate for this temporary vacuum, public health projects desperately need to be staffed and resourced, but all were in short supply. The problem of workforce was particularly acute immediately after liberation. There were only 1,500 doctors in Korea, and half of them in Seoul. There were even fewer nurses, only 1,300 in total. The gap between urban and rural health workers were already severe. Another problem was that most of the medical professionals were trained under colonial rule and had no experience in community-based public health work and were unfamiliar with the concept of public health. Meanwhile, the U.S. military government sought to strengthen expertise by sending 10 Korean doctors to U.S. in November 1945. The program, planned by the U.S. Department of Defense and funded by Rockefeller Foundation, trained Korean medical professionals in U.S. medical schools. Since their return, these trainees had a major impact on Korean medical administration and practice. However, there was a practical barrier. A small number of doctors was not enough to develop the public health projects that covers the entire population. Against this backdrop, the U.S. military government emphasized the role of nursing. In establishing a new medical system in Korea, as doctors with Japanese medical training were not willing to embrace the new concept of public health. Nurses, on the other hand, could be trained in a relatively short period of time, and since there was no established curriculum, the U.S. military government had the advantage of developing a new curriculum that fully embraced the concept of public health. In this process, the status of nursing, which has not been fully recognized as a medical profession during colonial period, was elevated. Establishment of the Nursing Bureau under the Ministry of Health symbolized this change. The first public health center under the jurisdiction of the U.S. military government was established in October 1945 in Seoul as a space for the new concept of public health and nursing to be implemented. Although there has been discussion about the establishment of public health centers since the late colonial period, resource limitations and the escalation of the war prevented establishment in Korea. The main functions of the centers were public health administration, epidemic control, maternal health, child health, environmental health, oral hygiene, and health education. It was nurses who were responsible for the actual work of delivering the new concept of public health to the community. Each health center was initially staffed with doctors, nurses, technicians, and administrative personnel to provide preventive health service such as education and home visits. But given the absolute lack of medical resource in Korea at the time, the health center were forced to allocate most of their time and resource to curative work, rather than preventive, as it was initially planned. As a result, the appointed doctors devoted most of their time to outpatients, while other preventive health initiatives became the responsibility of nurses. The center also became a prototype for health centers that were subsequently established throughout Korea, and a key space for training health personnel and accumulating field experience.
People and health centers.
As of April 1946, the medical facilities operated by the U.S. military government included a dispensary for the U.S. military personnel in the government building, formerly the Governor General's building, a tuberculosis hospital in St. Mary's Hospital, a municipal maternal and child health hospital, a clinic in Seoul City Hall, and the Central Health Center. Their duties were quite extensive, including coordinating mobile clinics in doctorless village, organizing maternal and child health clinics, conducting home visits and emergency midwifery, inspecting hospital nursing administration, investigating the state of nursing schools education, inspecting the sanitary conditions of orphanages, nursing homes, refugee relief centers, and elementary schools, set administration of immunization, registering nurses, oversee qualifications and practices of midwives, and organizing and sponsoring nursing and midwifery associations. As can be seen from the scope of work, the role of the health centers was, in principle, preventive medicine in nature, involving direct visits and inspections to the community to check and manage public health rather than therapeutic medical treatment. In July 1949, the establishment of Central Health Center was legislated. It came under the authority of the Minister of Health and was intended to promote the cultivation of hygienic ideas among the public and the institutionalization of health needs. It was divided into the following departments: infant, maternity, tuberculosis, venereal diseases, oral, and health education. The main activities of the health centers, as indicated by the establishment of the department, were focused on maternal and child health, chronic infectious disease control, and health and hygiene education. After its establishment, the outbreak of Korean War, coupled with manpower and financial difficulties, meant that the activities of the central health centers were relatively limited. But they provided a model for the health centers to be established in the future. Yet, There were a number of practical constraints on the implementation of a nationwide health program. The budgetary constraints are illustrated by the fact that as of 1947, only 2.2 million won of the Ministry of Health budget was spent on the establishment of health centers, representing only 0.3% of the total budgets at that time. By November 1948, there were only 10 health centers in the country, with one health center covering a population of about 560,000 people and mostly covering large cities. Despite their limited activities, the health center's main focus was epidemic control. After liberation, the returning population from all over the Japanese Empire was vulnerable to infectious diseases. And the socio-economic disruption created a condition for large-scale epidemics of infectious diseases. One of the biggest changes that the National Health Program brought to Korean life was the introduction of routine immunization. Starting in 1954, 7 infectious diseases, smallpox, diphtheria, whooping cough, typhoid, typhus, paratyphoid, and tuberculosis were designated as targets of routine immunization. The health centers played a pivotal role in mediating the national health program, but at the same time, the public perception of them was mixed. As healthcare in the private sector grew and university hospitals became larger, people's access to healthcare was mainly concentrated in the university hospitals or private clinics. While health centers provided a place to receive free treatment when economic conditions constrained, they also led the public to suspect that the free medicine provided by health centers was less effective than that was provided by other private hospitals. With limited budgets, health center facilities have gradually deteriorated, leading to a perception that health center provides low-quality service only. While the expansion of the health center network has greatly expanded the preventive intervention, many people still turn to private hospitals for medicine.